Introduction. Trilock 2.0, 2.3 4-corner fusion plate. I'm Dr. Ryan Rose from UT Health Science Center, San Antonio. Chapter 1, Anatomical Landmarks and Approach. Today we are going to discuss and show the approach for placement of the 4-corner fusion plate. I use this plate specifically for situations including slack and snack wrists where there is mid-carpal arthritis and it necessitates a scaphoidectomy and a 4-corner fusion. One of the benefits of the plate is that the inner 4 screws are cortical, so it brings the 4 corners together, giving you compression. The outer screws are all locking, so it stabilizes your fixation. Here you can see me marking out our incision where we go just ulnar to Lister's tubercle and in line with the third metacarpal. The third ray is generally the central axis of the forearm. I incise through skin and dissect down to the extensor retinaculum. I know the superficial nerves as well as veins are superficial to the extensor retinaculum and in the superficial fat plane. Therefore, I elevate full thickness flaps, protecting the structures. This will give me adequate exposure of the extensor retinaculum. Here you can see the extensor retinaculum, the extensor tendons. There are various ways to treat the extensor retinaculum. You do not necessarily need to release all the extensor retinaculum for the placement of this plate. Today, we will be. We will go directly into the 4th dorsal compartment, elevating out the other dorsal compartments and identifying the posterior interosseous nerve. Here you can see the posterior interosseous nerve, and you can address the posterior interosseous nerve as you deem appropriate. I tend to cauterize and take roughly a centimeter. The rationale for excising the posterior interosseous nerve is that it is a pain generator and can become entrapped in scar. I also extend my approach proximally, dissecting through the interosseous space and remove a centimeter of the anterior interosseous nerve in arthritis cases. Here we place our wheat liner deeper, protecting our tendons and giving us a view of the capsule. There is no reason to go into the 5th dorsal compartment, as the floor of the 5th dorsal compartment is the DRUJ. After identifying the capsule, we make an inverted T capsulotomy at the dorsal rim, being cautious and mindful of the 5th dorsal compartment. Here you can see the scaphoid, Lister's tubercle, capitate, and lunate, as well as the SL ligament. At this point in time, I will incise through the SL ligament. I next place a 2O K wire into the scaphoid. Under fluoroscopy, I will confirm the placement of the K-wire into the scaphoid. Often, in significantly arthritic wrists, there is abnormal anatomy. I then begin freeing up the scaphoid. When appropriately freed, I then use a wide mouth rongeur and remove the scaphoid in block. Here you can see where the scaphoid was previously seated. You now have an excellent view of the radioscaphocapitate ligament and the long radial lunate ligament. Now you can see the 4 corners being the capitate, the hamate, the lunate, and the triquetrum. So now I will place a pin in the capitate to gain control and pull traction. I will flex the wrist to get the appropriate view of the proximal pull of the capitate as well as the lunate. I begin denuding the articular cartilage. You can use osteotomes, burrs, rongeurs, and curettes. I then continue denuding cartilage of all the bones that make up the forecorner. Chapter 2, Plate Placement. I will now bring in the plate that we are planning on using. Under fluoroscopy, I'll confirm the forecorner position, ensuing the appropriate location for the reamer. We now begin to prepare for reaming. You will see that the top edge of the reamer serves as the indication for the reaming depth. The plate inserts directly beneath the dorsal bone surface in order to avoid any impingement in extension. Now at this point in time, you can decide whether or not autograft is needed to aid in your fusion. In this case, we elected not to. I then begin placing the cortical screws. I generally place the first screw in the capitate because it is often the longest and the most secure. You can now see that after fixation of the capitate, 3 additional cortical screws are placed in the remaining 4 corners. After the 4 cortical screws are placed, then the remaining holes are filled with locking screws with the goal of having 2 to 3 screws total in each of the 4 corner bones. Here you can see motion of the wrist with all 4 bones moving as one solid unit. Here you can see all 4 corner bones have the appropriate amount of screws placed with excellent coverage. On the lateral, you can see placement of the plate is below the surface. Therefore, there should not be any impingement in extension. I will then close the capsule with 4O fiber wire, the extensor retinaculum with 2O vicryl. If I have released the EPL tendon entirely from its compartment, I will leave it outside of the extensor retinaculum. I then will close the skin with 3O monocryl and 4O monocryl. I will then splint and transition into a short arm cast for approximately 6 to 8 weeks, or until I start seeing union at the fusion site. At that point, I begin range of motion.